Good morning, remote attendees. Doing a sound check. Brian Alston, can you hear me?
Yes.
Thanks, Brian.
Go ahead and call the Finance Committee meeting of the Cook County Health and Hospital System to order. Will the Secretary please call the roll?
Director Green?
Present, and having mute button problems, but present. Thank you.
Thank you. Director Harrington?
Present.
Director Lowry?
Present.
Director Robinson?
Present.
Chair Ryder?
Ryder is here.
You have a quorum.
Thank you. Can I have a motion to allow Director Green to remotely participate in the meeting as a voting member? So moved. Motion's been made and properly seconded. Any discussion on the motion? Hearing none, all those in favor signify by saying aye. Aye. Opposed? You guys have it. All right. The next regular meeting of the Finance Committee is scheduled for Thursday, November 13th at 10 a.m. Deb, is anyone registered to provide in-person or virtual oral testimony?
We did not receive any registrations nor any written testimony.
Okay, so no written testimony was provided. Is there any members of the public here today that did not register but want to submit, wants to speak? Anyone? All right. Hearing none, I'm going to move on to the first action item, the September 11, 2025 Finance Committee meeting minutes. These were approved at the September board meeting, but are being presented for the committee's review and discussion if necessary. Are there any corrections that need to be made to the minutes? Any corrections to the minutes? Any corrections to the minutes? Hearing none, is there a motion to accept item 3A, the September 11, 2025 Finance Committee meeting? You guys have it. Items under the Chief Procurement Officer. Welcome to the stage, Charles Jones, our Chief Procurement Officer. I will note the request number 2 is being withdrawn. Am I correct in understanding that, Charles?
Yes, sir.
Charles, before we bring up our first contestant, do you have any comments, umbrella comments you'd like to make, or introductory comments?
Yes, sir.
All right.
Good morning, Charles Jones, Chief Procurement Officer, Health System. With the withdrawal of number 2, we have 14 items before you today. all 14 require responses letters from the Office of Contract Compliance. We have 8 back and 4 in, 6 in progress. Thank you.
All right. Request number 1 is being presented by Aaron Galiner, our Chief Administrative Officer for Health Plan Services. Aaron, welcome.
Good morning, directors. Good morning. This first item is a no-cost extension for vendor OneUp Health. This vendor provides services to us that allow us to meet our CMS interoperability requirements. We also have a RFP related to this that just concluded, so I expect we'll also be bringing a new contract forward in the next board meeting or two for the go-forward contract.
Any questions for Aaron? Hearing none, thank you, Aaron. We're going to move to request number 3, being presented by Dr. Thomas Nutter, our Chief Behavioral Health Officer. There's 2 things in the world that I hold close to me: my behavioral health professionals and my cardiologists. So that's what's going to get me through my 50s.
Thank you, Chair Ryder. This is a $300,000 24-month contract awarded through an RFQ task order to do an assessment of billing practices and capacity of community-based organizations. This is part of our role in trying to expand access countywide, not just within the CCH system, and we assume we'll have recommendations from this project within the next few months. Happy to take any questions.
Are there any questions for Dr. Nutter? Hearing none, thank you, Dr. Nutter. And we're going to move on to request number 4 through 5, being presented by Dr. Lawrence Smith, our Chief Medical Officer, who I believe is going to be doing this remotely.
Good morning, directors. Can you hear me? Yes, good morning. Can you hear me? Can you hear me?
We can hear you.
Yes, Dr. Smith, they can hear you. We can all hear you.
Okay. Thank you. Good morning, everyone. The first contract is an execute contract with... Okay, the first contract is an execute contract with Deploy Synthesis. This is in the amount of $1.6 million for a 36-month period for spinal supplies regarding spinal implants. This is a GPO through October 31st, 2028. The next contract is an execute.
Go ahead.
Okay. The next contract is an execute contract with Flexicare. This is a sole source, as it is exclusive. It ensures compatibility with current equipment that we have. This is for our anesthesia department in the amount of $480,000 for a 36-month period, again through October 31st, 2028.
Okay.
And the last contract is with Patterson Companies, an execute and increase contract. This is to extend us for a 4-month period in the amount of $700,000. There is a concurrent RFP going on, which is the reason for the 4-month extension that would take us from November 1st through February 28th, 2026.
Okay. All right. Any questions for Dr. Smith on any of these 3 items? Hearing none, thank you, Dr. Smith. We're going to move along to request number 7 through 9, which are going to be presented by Shannon Andrews, our Chief Equity and Inclusion Officer. Good morning, Shannon.
Good morning, sir. Good morning, directors. The first item in front of you is a request to extend and increase a contract with Deloitte Consulting. This is a 7-month extension taking us through June 30th of 2026, and this is the finalization of support of implementation of our optimization efforts in the supply chain management department. The total is not to exceed $1.4 million. The next item is for Housing Forward. This is a request to extend and increase a contract with Housing Forward out of Maywood, Illinois. They provide supportive services within our medical respite program. This request is for a 12-month extension, which will take us through August 31st of 2026. There's an additional $300,000, the request for the increase, which is ARPA funded. And the last item is for Vizient, Inc., our GPO provider who is providing project management and subject matter expertise for the implementation of our inventory management systems. There's a three-phase approach to their support. This is the first one-year renewal option on this contract, which will take us through October 31st of 2026. And the increased amount of $640,776.
Any questions for Shannon? Hearing none, thank you.
I have a request.
Sure.
Yeah, regarding, contract, number 8, request number 8, the Housing for Maywood, they're the vendor. Be interesting to see, how that has been going, what's been happening, and, if there's some way to look at it in terms of improvement of patient outcomes.
Absolutely. We're happy to provide that information. Thank you.
I have a follow-up question relative to item request 8. Shannon, you shared that the fiscal impact, those are ARPA-funded dollars, correct?
Yes, sir.
And would you again, what's the scope of this contract?
They provide the supportive services within our medical respite program. You may recall on the outskirts or during the COVID crises, Cook County Health joined forces with Housing Forward to identify spaces for individuals who were discharged from the hospital but still required medical assistance but had no where to recuperate it. This program started under that umbrella, at least in terms of our partnership, and it has expanded its reach, initially sort of targeted for the western suburbs and western parts of the county. It has expanded in terms of having referrals from Cook County and some of our other partners in the area. So it's essentially temporary housing with a healthcare respite support that we do in partnership with Housing Forward.
But just us now that we're looking at no longer having an active role relative to housing as part of our county care offering?
Certainly, we continue to partner with County Care. County Care is currently in the final stages of an RFP process to look at reimagined housing support. I take those liberties with my colleague, Aaron Galiner there. So they are certainly looking at standing up support in different ways than or new ways relative to how they've approached the work in the past. But certainly Housing Forward has a very large footprint in the county, in the surrounding area. They have partnered with other entities or departments within Cook County to ensure that their subject matter expertise and the scope of the work that they do continues to be elevated in terms of, in our current setting. And as we move forward, I think we will all be even more pressed upon to find collaborative ways to partner and, again, to leverage the different expertise and perspectives that we bring to the work that we do. So I can't imagine that Housing Forward would stop being a partner. We will just continue to be creative and innovative in terms of finding efficient ways to do that in the current climate and beyond.
And one last question. What's the duration of this contract?
This will take us through August 31st of 2026.
Got it. Okay, thank you.
All right, thank you, sir.
One other question. And you've been doing this since September, or it's been going on before then?
The partnership began during COVID for this respite work. We were fortunate enough to receive ARPA funding to continue and to expand work that had begun. So this is not a new program under ARPA, but rather ARPA dollars were given to help support the work and to continue it.
So we have some years that we've already done this.
Yes.
So
We started, in fact, this contract, if you go back and look, started in October of 2022.
Oh, okay, so we have a
But we were,
significant-
but we had a partnership with them prior
Right.
to 2022 as well.
Okay, so, which is great, because my question is, goes to some of the comments that were made earlier. Can we look at, we have those individuals, we know what their diagnosis was. So can we look at 7-day, 30-day, and 90-day readmission rates? This will prove or disprove the impact of providing housing to those who need to help recovery. Because the belief is that that's a big part of helping. So we can look at those individuals and say, what was their readmission rate? That will tell us a lot.
And absolutely, we have data. Quite frankly, this body has approved previous contracts with some of our research partners. We have a clinician who has partnered out of this program with programs out of Loyola and other spaces to look at the data as it relates to how these types of programs have been helpful. So we'd be more than happy to share with you some of the data and metrics and research that has been done about the importance of these types of projects and programs and partnerships.
Sure. I think that would be very interesting.
Yeah, we'd be very happy to share. Like I said, we've had multiple contracts and partnerships with researchers and folks who have helped us to take a look at, to continue to support the justification for these types of programs.
Sure, and I'm quite sure there's some more data that will tell or not tell us the story as far as justifying it. I just simply gave some of the quick off-the-cuff numbers that would help, but there's more, it's richer data that can be mined for sure.
Absolutely.
So that would be fantastic.
Absolutely, and I'd be happy to share it with this body.
Okay. Any other questions for Shannon? Thanks, Shannon.
Thank you.
We're going to move on to request number 10, which is going to be presented remotely, I believe, by our General Counsel, Jeff McCutcheon. Jeff?
Thank you, Chair Ryder. This is a request to increase the contract with this law firm by $100,000. This firm provides regulatory advice on various matters, primarily for county care, and the firm is a county-certified WBE.
Okay. All right. Sounds good. Any questions? Hearing none. Thanks, Jeff. We're going to now move to Craig Williams, who has an endless amount of things before us today. Craig is our Executive Chief Operating Officer. It's still a lot relative to everything else we're doing, Craig. So.
Okay, the first one I have is for corporate cleaning services. This is an extend contract with no fiscal impact. We're asking for a 12-month contract extension, 6/1/25 through 5/31/26. And they provide window washing services to Core, Provident, and Stroger.
Any questions for Craig on this item?
The next is Dayspring. It's an extended increased contract for $1.6 million, 6-month contract extension, 12/1/25 through 5/31/26. And they provide our janitorial and cleaning services for our ACHN clinics. We're actually in process of doing an RFP for this service set, but asking for this 6-month extension to get through that process.
We've always had, I feel that we've always had like a limited number of people who've responded to this RFP in the past. Are we getting a robust amount of folks responding to the RFP?
Charles Jones, Chief Procurement Officer. This last one that entered into this contract, we have 6 responses.
Okay, great.
And the last one I have is for Schneider Electric Buildings America. It's an execute contract for $154,362, 12-month contract period, 11/1/25 through 10/31/26. And this is for engineering support, health checks, equipment replacement for our security systems at Provident ACHN clinics, as well as the 2 parking garages one at Provident, one at Stroger. This is a sole source, because this vendor has specialized expertise on our security infrastructure that we have in place. Yes.
It also indicates that they're going to be designing engineering services for Cook County Health Security System. What does that consist of?
So right now, we're redesigning the security systems in the 2 garages, just to make sure that we have complete eyes on everything that we need to see there. And we continue to look overall at our security system posture to make sure that not only can our cameras see everywhere, but they have the appropriate definition and as well as recording capabilities.
And they provide routine reports of what they find?
Yes.
Findings. It'd be interesting to see some of those findings.
Sure. We could bring in Superintendent Carter to talk about not only, what we've improved, but our plans moving forward.
This is just a quick tangent related to security, specifically in Providence. I know this has to do with our parking garages. We had the incident, how long ago was it now? A year-ish?
9 months or so.
9 months ago, yeah. Have we looked at further security protocols for those in the ED? I know from talking to folks, there's a couple places that are potential pinch points in the ED to just make sure that we're protecting the safety of our staff and our patients.
Sure. So specifically that incident, we actually added in, if you remember, that actually happened in the physician workroom, so that the patient was able to access that workroom. And so we've added a door to that workroom with cameras on both sides. We've also created some better access controls to the back doors of the ED, because what we saw during that incident was employees were not only responding, but they were coming in to sort of see what was going on. So we've made sure that we looked at people that had access to that door to ensure that the right people had access to that door. We added, I think, 2 camera points within the ED also. So our superintendent of security is constantly looking at ways to kind of improve our security posture, as well as how we work and interface with local law enforcement. So
yeah, there's one thing, and it's anecdotal, so I would just ask that you look to see if there's an issue there. Is that there's a couple of dead end spots that I'm aware of.
Okay.
So let's just see if that's true, and if we do have a couple dead end spots, see if there's a way where we can punch a hole in the wall to put some way to get through. And I know that's an old building, and punching a hole in a wall in an old building isn't easy. So
yeah, it's like Kool-Aid Man, because it's all cinder blocks.
Oh, that's why I prefaced it.
Yeah.
That's why I prefaced it.
Yeah, we'll take a walk and take a look at that.
Yeah.
Okay. Thanks.
Yeah, I assume by access, people access that room via their ID,
Yes.
and there's a possibility that people walk in behind them if nobody's paying attention.
That is always that's always a possibility. It's part of our training at both orientation and annual training that talks about security and not having people fall in. Can I say we're 100% foolproof there? Absolutely not. But
Do we have
continue to train
cameras
it.
so we know who's going in and who's going out?
We do, but I'm not sure that's an effective tool, right? Because it's kind of hindsight, seeing what we have on it.
It's way up.
Yeah.
Well, I mean, it's an investigative tool afterwards. Right. So there's relevance for that. I mean, there is a cultural thing that exists in every institution, where you see this a lot with this comes up. I don't know if it actually happens, but it comes up in school shootings and other mass shootings. Is that, and not to say that that's what this incident was not that. It could have turned into a much uglier incident, but that wasn't that incident. People holding doors, propping doors open, or doors not properly latching. So, on the facility side, just as we continue to make sure that doors latch, and I know that you. By the way, I'm I troll Craig a lot, but I really also have a great appreciation for the work that him and his team do. I just like having fun with him because he's from Boston.
I think we have, we have a couple things in play on that, not just beyond our security controls, but we do environmental care rounds. Lisa Brown, who is our Chief Safety Officer, does weekly environmental care rounds. We also we have a company that comes in from the outside and looks at all our doors to make sure not only are they latching properly, they have the appropriate smoke controls and all those things. So we do have a couple of different ways that we look at that. I'd also say we become very vigilant around people in the hospitals without IDs, so we'll call them out. So, if you guys don't have your IDs on, we'll call you out in the hallways. But we look for that visibly and to make sure that people are appropriately badged, and we've done a lot with our vendors, both with badging and vendor mate, to ensure that we have people who are properly credentialed within the institution.
Yeah, and you can't say it too often enough that it's not rude to, when you're going through a secure door, to not hold the door open for someone coming behind you. You don't know what they may have a badge on them. You don't know what areas that badge allows them to get into, and so you're not the security person. You go through that door. The person wants to get through that door, they can swipe through.
Plus, if you don't badge into this building, you don't get credit for using your space, and we may take it away from you. So that's another added incentive.
Thanks.
Thank you.
Craig. All right. We're now going to move on to requests number 14 through 15. We're going to hear from Donica Austin Cathy, our Chief Hospital Executive for Stroger.
Thank you, and good morning, directors.
Good morning.
The first one is an extend and increase contract with INO Therapeutics for inhaled nitric oxide in the amount not to exceed $374,590. The revised contract period of 9/1/2025 through 8/31/2026. This contract allows for the provision of inhaled nitric oxide for the pharmaceutical grade gases. This request includes the delivery systems of the INO gas for the Department of Pulmonary, Neonatology, Critical Care, and Respiratory Care. This is a sole source as the vendor owns the patent rights for the product and delivery of the nitric oxide.
Any questions for Donica? Thank you, Donica.
And the next.
We'll go to the last one now. Sorry.
Okay. Thank you. And the next one is an execute contract. This one, actually, I am the executive sponsor, but I do want to thank Craig Williams, Adam Weber, and Joseph Price for their partnership on this one. That's a lot of heavy lifting. This is for the planned replacement of the end-of-life radiology equipment across Stroger over a 3-year period. The execute contract with Siemens Medical Solutions for MRI, software accessories and installation, interventional radiology suite equipment, software and accessories, also for CT equipment, software, accessories, and installation. The contract period of 12/1/2025 through 11/30/2028, in the fiscal amount not to exceed $23,272,761. The vendor will provide 4 new MRI equipment, including software, accessories, and installation, 3 new IR systems, including software, accessories, and installation, 7 new CT scanners, including software, accessories, and installation, all for Stroger. The equipment will be delivered and installed over a 3-year period in conjunction with the Cook County Department of Capital Planning projects for the room preparation, readiness, and build-out.
Yeah, I have a question. What's our plan relative to patient access? Because you're going to be taking large pieces of equipment out, bringing in large pieces of equipment. So I'm assuming there's a collateral plan about how you're going to manage the patients and what's going to happen at that time.
Yes, and thank you for that question. So we have, so the operations team has been closely working with our, the capital planning and construction team. So there's construction kickoff meetings that include all of the clinical team as well as the construction team. Then we spin off and really talk about, the patient navigation, the process to make sure that no patients are impacted in any way.
So when is this actually going to start?
So this is over a 3-year,
The start date?
the beginning, so we won't be starting anything until 2026.
Okay. So 6 months into 2026, we'll know what's going on.
Absolutely, we certainly can provide updates.
So let's see if there's any disruption.
Okay.
All right.
Thank you.
I just want to add, this was a big commitment from both the CCH side and the county side to really replace all this aging equipment. It's well overdue and a good upgrade to the facility.
Awesome. Thank you. Charles, you got any closing comments before we move these items?
No, sir.
All right. With that motion, is there a motion to approve item 4A, contracts procurement items containing request numbers 1 through 15, with the exception of request number 2, which was withdrawn and subject to completion or review by contract compliance? So moved. Motion's been made. Is there a second?
Second.
Motion's been made and seconded. Any discussion on the motion? Hearing no discussion on the motion, all those in favor signify by saying aye.
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 Opposed? The ayes have it. Now we're going to move into the MBWB report. Charles?
Yes, thank you. All right, so you have before you the MWBE metrics for the second quarter of 2025 from March to May. Looking at the second column from the left for March, of the 30 contracts that you approved, 14 of them had contract-specific goals, $28.14 million. Of those 14, 4 vendors were prime contractors at $6.37 million and roughly 23%. 10 served as subprimes, subcontractors for $2.8 million. So overall, for that particular month of March, we had 14, all 14 did have participation as there was no waivers, for a total of $9.27 million, or approximately 33% participation. Looking at April, of the 23 that you approved, 8 of those 23 for $38.8 million had contract-specific goals. There was no primes awarded. 6 subcontractors for $9.9 million, roughly 23% of the participation. I always like to say, unfortunately, that we had 2 waivers for $1.89 million. The contract for healthcare-specific budgeting, financial reporting, and financial reporting systems for $249,000 was a waiver, and then a courier service for lab samples for $1.65 million ended up with a waiver. The month of May, 24 contracts, 12 of those were contract-specific goals, $122 million. 3 of those were awarded to primes for $25.7 million, 21%. 6 subcontractors, $12.9 million. So a total of 9 awards there for roughly $38.68 million, or 32%. Likewise, for the month of May, we also had 3 waivers. The neonatal clinical services for Humboldt Park Health Center, $600,000 was a waiver. The clinical service agreement for $18 million was a waiver. And healthcare evaluations and strategic advisory services for $900,000 end up being a waiver. So that's $19.5 million. Looking all the way over at the far right column, that's the year to date, 52 contracts and $513 million. 10 prime vendors, $33.64 million. and 35 subcontractors for $94.3 million. Overall, 45 awards for $128.03 million, and roughly 25% for year-to-date. Debbie, you want to roll to the next page and have a visual on the percentage of participation. Any questions? Yes, Commissioner Lowry.
What effort at participation is required for entities before a waiver will begin, either full or partial?
So the Bureau of Enterprise Development, which is the former contract compliance, they work with the vendors on their participation requests, and then after, then they take it to a waiver committee on the county side for an approval, and then they issue a waiver if all else fails.
And then relative to the awarded contracts for the first 6 months of FY25, how does the 128 compare to the first 6 months of FY24?
I'll have to get that data for you.
Please do.
Yep.
Thank you. That's all I had, Chair.
Thank you. Reported emergency purchases, Charles?
Yes, sir. We have on September 12th, we forwarded a memo to Board Chair Gaza and Finance Chair Ryder for an emergency purchase to pay vendors for providing COVID-19 vaccines on behalf of the Department of Pharmacy. Previous COVID-19 vaccines were provided at no charge to Cook County Health under the COVID-19 public health emergency. So this was an expenditure, a one-time expenditure payment to Pfizer, Inc. in the amount of $357,774.88.
All right. Any questions? Hearing none. Thank you.
All right. Thank you.
Are you giving, is your whole report full, Scott?
We're going to tag team.
Okay.
He's going to provide the report. I'll add commentary.
All right. Well, then we're going to go to items under the Chief Procurement Officer being presented by...
Financial officer.
Oh, Chief Financial, I don't even know what I said. So items under the Chief Financial Officer being presented by the CFO, Pam Casera, with her dutiful colleague.
CFO.
Yeah, Scott Spencer. So, first up, we have grant award related items. I'm just going to let you guys figure out who's talking.
Yep.
Gotcha.
Go ahead.
Yeah. Good morning. So, yeah, we've got the grants receive and file report in front of you right now. So we have just under $5.5 million, of which $842,000 are new awards, and $3.4 million are renewals, and the 1.3 are increase in extensions. And then as far as grantors, $2.4 million coming from the Department of Health and Human Services, 1.2 coming from the Illinois Department of Health and Human Services, and just over $1 million coming from IDPH. And the others are smaller awards. Any questions on that?
Any questions? Hearing none, is there a motion to receive and file item 5A, the grant award related items?
So moved.
Second.
Motion's been made and seconded. Any discussion on the motion? Hearing none, all those in favor signify by saying aye.
Aye.
Opposed? You guys have it. All right, we're now going to go to receive and file transfer of funds.
I'll take this one, Scott.
Okay.
So we do have a transfer request coming to you this month. It's a large request, $33 million. And this, again, does go to the county board to be approved as well. So we want to make sure that we understand why the transfer is needed. The from column, most of the from is coming from surplus in salaries and wages due to some of our vacancies. And the to column, the bulk of the $33 million is going to pharmaceutical supply expense. And we have numerous reasons pharmacy is running over cost this year. We have 3 locations that are non-340B eligible locations, 3 new clinic locations, Bronzeville, the dialysis center at Provident, and prescriptions that are done through virtual immediate care. We also have a lot of specialty medications, more than we budgeted anyway, being prescribed, and high-cost drugs as well, rheumatoid arthritis, gene therapies, things like that. And then just changes in the contract pharmacy regulations. More and more of the vendors are actually denying us 340B pricing. They actually want to go, I think we may have spoken to this a month or two ago, to more of a rebate rather than granting us reduced pricing up front. They want us to pay full price and then get a rebate on the back end. So there's a movement afoot to change the way that works. So those are the things contributing to the cost, and as a result, we're having to transfer more dollars to their budget.
Question.
Chair Robinson. I guess not Chair, Director Robinson.
Guy on the side. What allows them to change the structure?
Yeah, just the regulations, as there's all the federal regulations that are being,
Oh,
looked
this
at
is
right now.
as a result of.
Right.
Okay, well, just for the record, the reason why they give us a discount is because.
So I'm not versed on all the 340B regulations. I don't know, Donica, if we haven't, did we have Catania join us today? No? No. But basically, if you meet certain requirements, you are entitled to the 340B pricing.
Okay. So there's a.
And which, in most cases we do.
So there's a recognition that under these circumstances,
Right.
you should not have to pay X amount.
Right. We get a reduced cost from the vendors.
Is that number a hard number? Because you know numbers, and if I give you a rebate, then that means I get to use your money, and and so that the full discount is not being taken advantage of by us.
Sure, because of the time value of money,
Mhm.
but correct. There's going to be, we've been fighting this. This talk has been going on for multiple years, and we've been fighting it. But there is a pilot that we will be doing with one of the vendors and going to the rebate process to see how it affects us.
Okay.
So.
Well, I mean, just generally speaking, I've been dabbling a lot in pharmaceutical issues with health plans and stuff like that. Rebates are all bullshit to begin with. It's just,
Did you
there's like,
say that?
yeah, because it's money that the pharmaceutical companies, like in anything, there's the price that they want to bring to market that exists in multiple levels, and it's how you structure how the price gets there and what you're holding back, and how you're taking advantage of the regulatory scheme to do it. So, I also understand that sometimes with some drugs that we're paying the cost of developing the drug. There has to be a better way to ultimately do all of this, because the amount, the sensitivity, especially right now with all of the gene therapy and everything else that are on the market, we're potentially saving lives and crushing people at the same time, and institutions, with the cost of doing it. So, but good news. It seems that Health and Human Services is an advocate for, making pharmaceuticals more available and subsidizing the costs of drugs and making sure that life-saving medications and vaccines are available to everyone. That's not an accurate statement. That's me engaging in sarcasm and satire. Okay, Joe.
Yeah, so what we're really talking about a movement of paper, not actual cash or anything. It's not substantive.
Oh, there's cash being moved.
Right. Well.
On the contrary, because if I give a discount, then that means I get a tax write-off because I gave a discount, but I'm getting a tax write-off, but I'm not really giving a discount because I got the money because I held the money longer. It's not hard math.
Yeah, I understand what you're saying. All I'm saying is like smoke and mirrors. I mean,
Okay, I can go with smoke
Right,
and
the
mirrors.
money's going back and forth, but it's not like real money at any particular point. They get a rebate, we get a reduced cost, and I don't know if they offset each other. I think that would be the big question. Is it offset? We'll probably never know.
That's not a hard question, because they're giving us a discount because they recognize that we are a safety net hospital and we are providing a service that is much needed.
But we don't know
And so
the
we
cost
should not
to
be
bring-
paying the premium, because I understand the value and the pharmaceutical R&D pipeline. I understand it very well.
Right.
I'm not arguing against them making money, but this is not the place for it to be done.
Yeah, I would agree. I think what we don't really know is what is the cost to bring a drug to market?
That's my point, is that
We don't know.
there's no transparency in the process. Everything is, and I think at a certain, I think we're all driving to the same point.
Right.
I think the issue is that Director Robinson thinks we could discover it. I think we could potentially, there's ways to figure out how this is all working, but the way it's all layered is to make you feel like you're getting something when you're not really getting anything.
Right.
Which I also think is part of Joe's point too, is that it's just all paper moving, that the price is the price is the price, and it's just,
Well, my argument is for those who are saying it, but they're actually getting a discount,
sure.
and that's the issue.
Yeah.
The discount that's supposed to be given to the people.
All right, you were on pharmaceuticals.
Yeah, so all that
On
to
the
say that
transfer.
we need to transfer $33 million to pharmacy to be able to cover the increased
Okay.
cost. Any other questions on that? All right.
Is there anything, is it just pharmacy or is there anything else?
There is, I think, a couple lines there for county care. Due to the higher membership, they're having to transfer $5 million to professional services and $2.5 million to registry services, due to the higher membership and I can't even read this, it's too small. Higher membership and third-party administrator fees, benefit managers, and the cover costs associated with management functions.
Okay.
Yep.
All right, great. Any other questions on item 5B? Hearing none, is there a motion to receive and file item 5B, the transfer funds? So moved.
Second.
Motion's made and seconded. Any discussion on the motion? Hearing none, all those in favor signify by saying aye.
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 Opposed? Opposed? The ayes have it. I believe we're now moving on to the August financials, which I had to guess Scott's gonna do.
Yep.
Okay.
Yeah, so, our financials through the month of August, so ending, the month, $93.2 million unfavorable, to budget on a cash basis, however, $21.6 favorable to budget. Explanation remains largely the same, net patient service revenue unfavorable to budget, due to the lower than budgeted volumes and increases in charity care. However, capitation on the health plan side remains favorable. As you'll see later in the deck, county care coming in just under $49 million unfavorable with a membership just over 401,000. Next slide, please. So our income statement here, again, net patient service revenue, $159 million unfavorable, but adding in the capitation favorability of $282 million, total revenues are $120 million favorable. And as we look at expenses, $210 million unfavorable, comprised mostly of the medical claims expense of $333 million and partially offset by the favorability on the salaries and benefits line. Next slide. So our waterfall report here, just kind of showing the different pieces, the favorable and the unfavorable pieces in a different way. As you can see, the net patient service revenue and the medical claims in red, and unfavorable, and then capitation, salaries and benefits, and purchase services in green being favorable. And you can also see here how the capitation and the medical claims kind of offsets the favorability and the unfavorable offset each other.
And just to interject on this one too, you'll recall that mid-year we're projecting a pretty big gap as illustrated by our bottom line. We're still behind our budget. And at the May, we embarked on a 10% reduction plan, right, across all offices and all expenses. And you can see that reflected here, that we are closing some of that gap, right, by the savings that we're seeing, the greens, right, in salary and benefits, some of that coming from the positions we froze, other $92 million coming from positions we froze, and just the vacancies we still have. And then purchase services and other is another big chunk where we're favorable to budget, and contract labor falls in that category, right? And we've had a lot of efforts around reducing contract labor as well. So between those two, salaries and wages and purchase services, right, we've closed the gap $100 million there of that $184 million less net patient service revenue that we're seeing. So it's working. Just the payer mix, which Scott's going to get to, right, the shift from Medicaid to charity is happening faster than the savings we're seeing on the expense side. So that gap, we keep closing the gap, but the revenue keeps eroding. So, okay, next slide.
So our volumes here, average daily census at both hospitals below budget, as our ER visits and surgeries. Though I just wanted to point out that the variance at Providence is no longer widening. In fact, on the surgery side anyway, no longer widening and closing a little bit as GI has picked up in the last couple of months. On the ACHN side of things, primary care short by 7%, and specialty care ahead by almost 5%. And again, membership on the health plan side of almost 411,000, so 4.3 ahead of budget. Next slide, please. So as you can see on this slide, just our volumes for over the last 4 to 5 years, relatively steady. And always want to like to point out the outpatient clinic visits, the red line in the top left-hand corner. That at the beginning of the year, that line was starting to slope down, which would suggest that the 25 volumes were going to be lower than we anticipated for 25, or lower than 24 actually. But you can see that that line is flat for the most part. So, recovered some ground there. On the next slide, you can see our payer mix, Medicaid at 52.2%. So just a small change from last month. So holding pretty steady there, with uncompensated rather at 22%. Our rev cycle KPIs on the next slide. A couple things to point out here. So our accounts receivable days in total and AR days over 90. Despite the boxes being in yellow here, you can see that things have improved quite a bit. You can see that turquoise line coming back to the target line. So as the older claims get cleaned up, the AR days are coming back down, and overall the remaining accounts receivable ends up healthier. And then cash collections, just pointing out that they are at target for the month of August as well. Next slide. On our denials here, starting with the government billing denials, again, the overall trajectory there continues. As well as the net final denials. You can see that for this being the 6th month in a row that we are below the target of 2%. Next slide showing our charitable benefits and public program expenditures. So projecting, at this point, $650 million, which is driven primarily by the top two lines, which is our charity care and other uncompensated care. And to Pam's point, as the shift from Medicaid to uncompensated continues.
Questions? On the payer mix, when you have the uncompensated, you have an increase of 0.5%, and which actually shows a balance with the decrease in Medicare, Medicaid, and the commercial. My question is, do we understand what type of service the uncompensated are receiving? That's the first question.
We could. We'd have to dig into it and get that detail back to you, but yeah.
The other question is, how does that impact what's taking place at Providence? Because Providence just continues to be an albatross from a financial standpoint. It's just bad. So,
is your question how much of that is Providence?
yes.
Okay, we can look into that. We have that information. Yeah. Anything else on charity or?
Yeah, I'm through.
Okay.
I'm finished. Any other question would be a repeat.
Yeah. Next slide.
Excuse me. Yeah, and then, so our savings initiatives here, so we're 3/4 of the way through the year, so we're just ahead of that goal at this point at 84%, due to the revenue cycle initiatives, contract negotiations at County Care, and then the progress that's been made on the agency expense. And then last slide here, again, the County Care, the health plan just short a budget by 51 million due to the higher medical loss ratio, so due to the higher cost drugs and the NICU cases. So as the bullet shows here, there are some discussions happening with the state regarding some additional reimbursement, but those dollars are not in these results. So waiting to see where that lands.
Scott, you added something new there. Beyond the specialty drugs, you said the NICU issues. What are those issues?
I would ask Aaron to answer that for you.
Good morning, Aaron Galiner, Chief Administrative Officer for County Care. We've seen over the past few years that we've got a differential number of NICU cases, particularly high-cost NICU cases, compared to the other MCOs. A lot of that likely relates somewhat to the uniqueness of the population that's in our plan as well as our network. So, for example, we're the only managed care organization that's contracted with the University of Chicago. So some of the high-cost specialty that's happening for NICU cases there, for example, we have more of that utilization than other MCOs because the other MCOs don't contract with the University of Chicago. We're also one of only 2 MCOs contracted with Northwestern, so that's another area where we see, purely in financial terms, some of that adverse risk. That being said, the conversation with the state is around this issue. And the way the rate setting works with the state, there's a risk adjustment process that happens generally to account for differences in acuity between managed care organizations and their population. But the one area that is not risk adjusted is this NICU area. And so that's the conversation we're having with the state right now, is that we have unique risk, and that's not getting picked up through the standard risk adjustment process to be appropriately accounted for. So that's the ongoing conversation with HFS right now that we're hoping will lead to some resolution.
Okay, so to try to get a better understanding, are you saying that, there are 2 questions here, I think, to help me understand. Are we saying that because we're going to Northwestern and University of Chicago, there's a higher cost associated with stepping foot in there. Then there's the other statement could be that we have a higher propensity to have people who have special cases that require more care, which then adds to the cost. Which one are we saying? Are we saying both?
So it's I would say all of the above. So there's when we look at the social risk factors in our population, we have a population compared to the other managed care organizations that has much higher social needs, and we've been able to sort of do analysis to document that to the state. So that's, I think, one factor that just leads to we're likely having more high-cost NICU cases because of some of the inherent uniqueness in the populations we're serving. So that's one component. The other component I would say is some of those most extreme NICU cases are tending to be served at some of those facilities like Northwestern or University of Chicago that we're uniquely contracted with, and so we're getting more of those cases than the other managed care organizations.
The cases that we're seeing, if we're talking prenatal, these are preventable possibly, and they're not getting the care, not that we're not doing a good job, they're not going for whatever reasons they're not going. Is that more the cause?
I think obviously there's things you can do to help to some extent prevention on this population. That's something that we've looked really closely at, and so when we look at, for example, at our quality scores for pre and postnatal care, we're hitting 75th percentile nationally on those scores. So we feel, I think, relatively good about just our management interventions with the population. There's obviously always more that we can do there. I think that some of these are cases that are likely not necessarily preventable, but we're just getting a unique number of these given how we're positioned in the market.
Does this impact the actual mother, or is this more the child?
Mainly the child.
Just for the sake of the lay public, what is a NICU?
So this is neonatal intensive care units.
This is happening at birth or after birth? I'm sorry, because this is a unique interest, because if we look at the dynamics of the population, and we say that we know that county care has a certain portion, we know that other MCOs have portions too. For us to be getting a disproportionate amount of them, it says, that's a very unique, interesting problem. So it makes me ask more questions, because the surface questions, they just simply don't get to the essence of the problem.
Yeah, so these typically are post-birth, they're long-stay NICU cases. So very complex cases where the length of stay, may be longer than 6 months, for example, post-birth.
Do we have anyone from nursing on that could speak to that? I mean, it's probably primarily premature babies, would you say, or do we know?
Hey, good morning. This is Bina. I can speak. Yeah, these are the babies born before, either has some diseases condition or prematurely, anywhere from 23 weeks to all the way up to usually 32 weeks. So they do stay long. Their length of stay is normally, beyond, 2 months. So all those factors contribute to the overall cost of the NICU care. If you have any questions, or I'm happy to go further on it. I'm a neonatal nurse by background years ago.
Yeah.
maybe I can have an invitation to come by and sit down and discuss more.
Happy to do that.
Before we leave this topic, I will share, Curtis Haley's on and did share with me that Stroger's uninsured is 20.8%, and Providence is 27.7%.
Well, that's not.
So it is higher, a lot higher. As far as the top highest services that fall into charity, he'll have to run that report separately, and we'll get that to you. But the Providence charity is quite a bit higher. All right. I think that concludes the finance report.
Thank you, Aaron.
Thank you. All right, great, thanks, Scott. We're gonna now move to our informational reports, which this month is, a report, and that's our monthly report on the agency reduction plan being presented by Wynn Buren, our Chief Human Resources Officers, and returning to the plate, Craig Williams, our Executive Chief Operating Officer.
All right, good morning. As you can see, our offer activity was strong this month. Year-to-date, we've made 1,685 offers with a 71% acceptance rate. We filled 1,113 positions. We're up 172 positions year over year. 811 were external new hires, and 302 were internal hires consisting of promotions and transfers. Separations remained steady. They're declining slightly. Overall downward trend in retirements, some fluctuation in resignations, and a decrease in discharges. And then we are at 404 net hires. So last year, this time we were at 217. We are up significantly, about 86%. Next slide.
This is a slide that should be familiar to this committee. It details our current state of agency use in total. For the month of August, we were down another 35 positions, down to 819 FTEs, which is about a 40% reduction from when we started tracking this back in September of FY24. For the month of August, just under 11% of our staff were agency employees. Next slide, Debbie. Sorry for the eye chart here, but this just details our top agency utilization by job code, and you can see across almost every category we've made some pretty significant declines to achieve that 40% reduction, and continue to work through onboarding both agency staff, but hiring new people from the outside to replace the agency folks that we have in place.
Craig?
Yep.
This is going to be my second tangential thing. And this is also, I should have brought some of this up during the finance report too. I know that when we're hiring folks, we go through a lot of verification processes and things like that. So, public bodies don't typically have a undocumented workforce. So I'm not coming at it from that perspective. But with everything that's starting to happen in the city, that has sort of an impact. And I'm not even really talking about our contracted services, but as we're working with folks on the floor, are we having to do anything supplemental with security and things like that? What are we seeing while we're doing this transition? As we have other things surging, and also, again, this is something I should have brought up here a moment ago. Our patient population, a portion of our patient population is probably not showing up anymore because of concerns of being outside of in spaces where they could possibly be detained, regardless of citizenship. So, I guess it's a broad question that impacts this, Because right now, I mean, I get it, we're heading, and I continue to appreciate the progress we're making, so.
You know, I think those are real-world issues that we're facing. I mean, currently, we've had a few interactions with immigration enforcement at the hospital system, most notably in patients that are detained by immigration enforcement and need medical care. Right now, we actually have an inpatient that's under ICE custody, which also required having ICE officers sort of guard that patient while he's here. What I would say is we've done a really good job, led by Superintendent Carter, to engage with all local law enforcement, but specifically around ICE. And our experience with ICE, although we may not agree with what they're doing, they've been respectful of our policies and have adhered to those policies for the specific incident. The ICE agents actually agreed to be plain clothes to try to minimize the impact on staff. That said, you know, we've done a lot to try to get out in front of the staff and talk about, you know, our policies we have, how that applies with what's happening within the walls. We've also been, where we can, having CCH police escorts. When that patient has to travel around, those immigration enforcement agents are in sight. But, you know, we're constantly kind of learning new things and trying to be prepared around that. You know, I would say we have not added any specific, like, security of police resources related to what's happening. I think we've been able to manage it pretty well, and that's really, I think, with the proactive nature we've approached all of this with and trying to engage with law enforcement.
Here's my concern, and this is why I ask it in the context of supplemental staff and security, is that from everything I understand, and I'm doing some work around this space, is that detentions are not necessarily targeted to a specific person. They're not showing up at a specific person's door because they have a civil or judicial warrant for detainment. They are profiling people in public and based on their occupation, their perceived ethnicity, and detaining them. So my concern is we have, under the guise of having people in custody at the hospital, what types of protocols are we putting in place that they are not then going to creep into an enforcement act, into what a quote-unquote detainment activity while they're here under the guise of having a detainee?
Yeah, I mean, we have strict policies around how we engage with law enforcement for our patients that are under detained, and they have strict guidelines on how they can interact with other employees, other patients, and they've been respectful and they've been following those policies. Those are the exact concerns. I think we actually had a huddle with our resident staff last week because we obviously have a lot of foreign trained residents, and they were very concerned about having immigration activity on the floors. We've been able to really talk through that and talk about how we've engaged and how they've been following policies and kind of create workarounds on that. So, you know, to date, I do think it's a risk. I will tell you that the same residents that initially raised this to us expressed some concern about those same officers over at the Chick-fil-A not acting the same way they were acting within the walls of our institution. Obviously, we don't have any jurisdiction over this. But we have a lot of staff that go to that Chick-fil-A, I noticed. We don't have jurisdiction over there. But I think, you know, they've been playing ball within the facility. And, you know, we haven't seen any activity where they've been canvassing outside or approaching people as they come into medical visits. And I don't think we have, and Jeff may be on and could comment on this, I don't know if there's a case nationally where they've interfered with healthcare services and tried to, you know, canvass people in that manner.
No, well, I don't know either. The thing that brings hospitals to the forefront is when Alderwoman Jesse Fuentes, who was asking an ICE agent whether he had a judicial warrant for the detainment of someone that was brought into another hospital. They elected, instead of there's video of it, I'm sure everybody's seen it, instead of engaging in an appropriate way or in a de-escalation way, they just spun her around, zip-tied her, handcuffed her, and threatened her with arrest, which, with an elected official in her district, in her ward, was highly, highly disturbing. So, that has everybody's anxiety up, because that, again, Jesse didn't make contact with the agent. The agent completely disregarded her status as a local elected official, and I'm seeing a lot of that disrespect being, a lot of different places. And I represent a lot of other industries, journalists who've been attacked by ICE agents during protests. Well, no, not during protests. Specifically, I think most people probably saw the CBS 2 reporter who was just checking to see if a protest was happening at the Broadview ICE facility. No protest was happening, and that reporter was tear gassed and shot with rubber bullets. So, Jeff, have you seen any incidents of anything happening at a healthcare facility?
No, there's not been any report of any incident like that happening at a healthcare facility. And it's unclear, the incident you referred to with the alderperson, it's unclear where within the hospital that actually happened. But under our processes here, the alderperson would not have had access to the area where patients are being treated. And that is the only place that we would have the ICE agent, directly next to the patient who's receiving treatment. And so if there were other ICE agents in public areas of the hospital that the alderperson had access to, we don't allow that within our facility. And so we believe that our current processes will prevent that type of an incident from occurring.
Well, wherever it was clear that there was no patient. There was no patient in the video. It looked like they were outside of an exam. They're outside of an exam room. How she came to be in that area. If you're going to engage someone like that, if someone is in a place that they're not supposed to be, ICE would not have jurisdiction to remove that person. If someone was at a part of our facility where they weren't supposed to be and ICE was there, it's not ICE's jurisdiction to remove that person. It would be up to hospital police or the county sheriff, or just being asked nicely to leave. The thing that encountering the problem I am concerned about as we keep getting engaged on this is it's a shifting landscape. Every day they push a little bit further. So I appreciate what you're saying, Jeff. My concern is that they're going to eventually change the rules, because it's going to, at first they were going after quote-unquote violent criminals, and now they're literally just kept grabbing people after they get off work, regardless of their citizenship. We were talking earlier about the service worker who was detained, who was a U.S.-born citizen, that they detained her for an hour and a half because, at least in part, she didn't have a Latino last name, and that made them doubt her documentation. And she went as far as to carry her passport in addition to her ID and her other credit cards and all that. So this is a very heightened situation. I believe Dr. Green has her hand raised.
Thank you. And before I say this, if I don't put the hand down, I wouldn't need help with that. I usually have problems with that. I know in spring, was it April, March, I think it was March, where we talked about mandatory training for all employees or all team members. And but I know I'm on a remote device. driving, it's going in and out. Um, this is a good time to check on the status of that? Any feedback on how that's going, how that went, the percentage of, team members who have gone through that training? And then there was a mark that, some thought about sharing out that training.
Yeah, so we're about 85 to 90% complete with that training. Some of the folks who haven't gone through it are either on leave, so we're just throwing up those numbers, and we've sent out some notices in the last week or two about completing the training. If it's not completed, possible discipline will follow. So we're following.
You said between 85 and 90? Sorry. You said between 85 and 90?
Correct.
Okay. All right.
And as we're onboarding people, from, the conversion, everyone's, are we retraining people?
Yeah, so it's in the new hire orientation, and then I think what we're trying to add it into is an LMS to make sure that it's tracked appropriately. So we just have some tracking mechanism challenges with that, but we're making sure that it's part of our regular onboarding process.
Yeah, because we can't count on the fact that they were working here under an agency provider and that they were getting the same type of quality training. Can we, for those who are, for those people who are still under agency contract, can we see where they're at with their program?
They're in that same number that he just quoted. So when someone's here in an agency where we require them to go through the same mandatory training.
Okay, all right. Bill?
Thank you, Chair. So, to the Chair's point, this is a shifting landscape, and it's important that all of us stay on our toes. I think in the coming days, our own policy will be revisited. So, we'll keep talking, and but there's more to come.
Thank you. Director Harrington?
Yes, just building off this, it's a fluid situation, and we don't know what's going to happen moving forward. But I would venture to say that our community-based sites are more vulnerable than our hospitals, because our hospitals do have security. And many of our community-based sites don't have security, and those are the ones I'd be most concerned about, because these things are happening at a community level.
So all of our community sites, all of our ACH and community sites do have security. At the time that they're open, they're all under the authority of Superintendent Carter through my office. I would also say that we are, actually, I should mention this at the beginning, we're an incident command related to the incident. And so we meet 3 times a week specifically to talk about immigration enforcement. And then we have the ability to call that group together anytime something changes. So we've called them together when the incident that Chair Ryder talked about, to go through what happened there and make sure that we were prepared for it and our policies affected that. We called again last Thursday when we knew this patient was going to be admitted. We were going to have officials within our organization to think about what that meant and other communications. So, I do think the incident command structure allows us to be fluid and continuously learn from what's happening and react in a way that kind of creates alignment throughout the organization. So we'll stay in that until we get to a better place on this.
This is a bigger question, and maybe more appropriate to take this topic to some sort of special board meeting. But there's going to be people who allege that they're being illegally detained, and that there's Fourth and Fifth Amendment issues at stake. Do we have any visibility into that, or are we walled off from it? And is there some sort of patient advocate? Being with some of these folks, they have, their status isn't necessarily that they're a violent criminal. They may be in process. So some of them aren't targeted, aren't being detained pursuant to a targeted incident. They're just walking out the back of a restaurant, let's say, and they look Mexican, so they're getting detained. And then the person gets, whatever happens, so there's an injury occurs or a health emergency presents itself.
I think right now that's a little bit beyond the scope of what we're doing. We're here to provide health care. We engage with the with outside law enforcement as they come in and make sure everything's on the up and up, in terms of
Okay,
that.
that's the question, is whether things are on the up and up, and whether
Completely
there's
agree.
habeas corpus issues.
Jeff, I don't know if you want to comment on that. I think that's, you know, outside, a little bit outside our scope right now.
Yeah, I can address that very briefly. So if outside law enforcement of any sort, being it ICE or the sheriff or the Chicago Police Department, brings somebody in their custody in for medical care, it is not within the scope of what we're allowed to do to make any determination about whether that is an appropriate custodial relationship. We have to operate on the assumption that it is, and then our obligation is to treat the patient. If they do not, if the outside agency does not suggest that they have custody, then we would not allow them in the facility.
Okay. All right. Well, again, this is not a mature conversation yet, and they sort of jumped us into this out of curiosity on our transition. So I'll bring us back to the main topic at hand, and then maybe we can have a broader discussion that includes more of our directors and more staff where they've had time to prepare.
Thank you. Next slide, Debbie, we can go through these quick. This is our provider agency, locum tenens utilization. This went up a little bit this past month, and that was entirely related to new providers that we onboarded in the cancer center to assist with provider vacancies. So we actually onboarded 4 physician assistants to help with overall patient throughput in the cancer center because we're seeing longer wait times there. Other than that, everything's been pretty stable on the physician agency side. And then is Mark joining us? Mark, are you on?
Good morning, directors. This is Mark Spranka, Chief Scientific Officer. Happy to report on continued progress on the staffing front. So this slide shows that 42 individuals have successfully onboarded at CCH as of last week. We have 69 remaining at MedX. We have 2 individuals scheduled on board in November, with many more coming on board over the next few weeks. The status of the 69, the good news is we've successfully gotten permission or approval for PIDs and request to hires for more than 60 of those 69 individuals remaining at MedX, and HR is working to post those positions. Many of the staff sitting at MedX are excited to apply for those positions, and we kind of process them. There's an interview process, and we do expect over the next month and a half to successfully welcome the majority of the remaining 69 individuals to join CCH. So sometime in December, when we have this standard monthly update, I do expect that we'll be reporting 90+% of individuals will have successfully onboarded at CCH. Happy to take any questions.
Any questions? All right. Any other questions? This is the last piece, right?
It is.
Any other questions for anybody on the team? 11% is a good number. Where do you think the number lands at once we? I know that we still find places where we didn't realize that we were doing agency here that we should be converting. It's a big system. But where do you think the number lands at?
I think it's in the 600 to 700 FTE range.
And what would that be?
Which is probably like 8%.
Okay.
You know, as I think about the things that we still have in play, there's a couple of big boluses that we're working on, so.
Yeah. Okay.
But that's just a guess.
Well, go ahead.
It'd be interesting to look back and see what were the pre-COVID numbers and make a comparison moving forward.
Yeah.
A lot of this is generated by not coming out, people being able to move somewhere and live and, so.
I will tell you that I think we're gonna end up lower than pre-COVID because we still had, I believe, overutilization. Yeah.
I actually think we've sort of fixed a lot of that, COVID ramp up. And a lot of that happened in the initial agency conversion and the moving around of PIDs we did at the beginning of this, like last fall. You know, I think that there's more systematic things in terms of, you know, our overall process, as well as just shortages around very specialized positions that we're always going to be challenged with.
Yeah,
industry-wide.
No one, there was never an expectation that we were gonna get this at zero, and I'll take a risk here, say that it was ever gonna get below 5%. Doesn't mean I wouldn't want you to try to get below 5%, but I don't think that's realistic just on some of the primary care positions that we have, because things happen, right? Things happen, and there's scheduling, you know, as best as we can get, it still has issues. The things we can fix.
Geographically dispersed, and we're specialized, and all those factors.
Yep.
Make recruiting hard.
And I think that exactly that there's gonna be gaps, because you can't have a bench full of people unless you have a on-call registry that's employed directly by the county, which we've talked about things like that before. It's just we're not there. But I do think that there's been an element that you guys have been able to correct of it's just easier to do this contract or piggyback off this contract, and I think there was a culture around doing that before COVID that got accelerated during COVID because of that you guys have been able to unwind.
It's
right?
too hard now. Too hard to bring people on. We need enough. We put a lot of safeguards in place. It's definitely, there's more rigor. I mean, we had our committee meeting this morning, so every single agency request goes to a review that Wynn, Pam, myself, Carrie all sit on. So
that's before it goes to BHR to make sure that we can actually do it. So we're very intentional about the conversations we have before we bring anybody on.
I just tell you guys, I know I've said it a lot, this is a much different organization at the middle and top than it was when I got here. The organization of our broader frontline staff, and I'm not putting people on an economic chart of that, I'm just talking about like authority level. Our frontline staff has always been great, because if you're a doctor or nurse, you don't go work at a safety net hospital because you think it's fun. You do it because you're mission driven, which I think we have a lot of mission driven people working in administration here right now, and I appreciate all the work you guys are doing to help support our frontline workers and make us organizationally a top flight institution. So, all kidding aside, Craig. All kidding aside.
Appreciate it.
All right. Any other questions?
No question, but I want to ask, did we give, is he still here? Aaron, a hand clap for the 4 stars?
We can.
Yeah, let's do it. All right, great. With that, our next meeting again is going to be November 13th at 10 a.m. We've exhausted the agenda. We're adjourned.
All right.